I want to add the tingling also about it. Then can you see the slide correctly right now? Okay. So I want to start my lecture. Before start my lecture, I want to ask one question, some questions. What is the cause of the numbness of these patients? 66-year-old female, sudden onset of left hand or leg numbness. Also, right face numbness is positive. Decrease the function of swallowing is positive, but no paralysis. So which place of the body or brain the patients have the problem? So lumbar spine, parietal lobe, cervical spine, medulla oblongata, or peripheral polyneuropathy. So please answer a little quickly about it. So maybe on your screen, the Zoom ask you a question, so please push and then send the message. So Dr. Harada, if many patients say answer, please tell me.
Okay. Almost half of the attendees are already answered the questions.
Okay.
So I'll wait another 10 seconds.
Yeah.
So I'm gonna close the poll here.
Okay. Thank you. So yeah. Okay. So very interesting. So diverse. The answer distribution is diverse. Medular and peripheral both are common. Parietal lobe, this is some also. Okay, interesting. So maybe after you finish this lecture, you may know the how to approach and how to think the differential diagnosis of this patient. Okay, let's continue. So numbness is a loss of sensation we call hypoesthesia. And tingling is an unusual sensation. We call it paresthesia. So these are one of the most common symptoms which patients come with in OPD situation. Sometimes patients may also have pain, but sometimes not. So the characteristics of this complaint is that this is subjective information mainly, which means sensation problem is mainly how patients feels. So careful and thorough history taking or ask careful question. What do you mean about the numbness or in each language of the patient is very important. So you need some technique or the experience to ask about it. Also, according to the history, you need to take adequate or enough physical exam to differentiate the diagnosis and list up the differentials. Okay, so today I will talk about the practical approach, how to approach the patients who come with numbness or tingling. So this is the most important message today. So to make clear diagnosis, to reach adequate diagnosis, the most important point is to clarify the distribution of the numbness or tingling into 4 groups. I explained later about what is the 4 groups, but the most important is please clarify the distribution. So even the patients come with right hand numbness, but you should ask, do you have any other place to have the numbness or tingling or other neurology you should check. Okay, so let's check move to the next slide. To consider the distribution, let's check about the pathway of the sensation first. So to feel sensation normally, sensory receptors must detect information in and around the body. These receptors is basically on the skin or muscles. Then sensory nerves from the skin or muscles goes up to the spinal cord through the brainstem. Then it reaches to the thalamus, which is located at the middle of the cerebrum. Then the nerve connects to the next nerve, which go to the somatosensory cortex and other brain areas associated for the sense. So you should understand the pathway, and then you should think the distribution of the patient's area fit for the pathway or not. Another important information is dermatome, which is a map of the nerve root area. So if you check the distribution and then again, you should think this patient distribution fit for the dermatome or other pathway or not, okay? So here I showed the 4 patterns. So according to the distribution, you can understand which category the patient's distribution is. Number 1 is brain or brainstem. Number 2 is spine. Number 3 is mononeuropathy. Number 4 is polyneuropathy. So this is very important. So according to the distribution, you should differentiate this group. Then you should focus more and more of each diseases. Okay, I explain one by one. So before that, also character and time course of the sensational problem is important. The onset is acute or chronic. If it's acute, you should consider about trauma or vascular disease as well as other disease. The frequency, intermittent or persisting, and also the symptom is improving, stay or worsening day by day, or any triggers which causes the symptom worse, or any position which makes the pain, which makes the numbness improve. You should ask about this character as well as other disease. So this is also very important. So let's go to the number 1 category, brain or brainstem area disease. So basically, this is the upper area of the pathway. So one side of the whole body, from the neck to the toe, involve the distribution. Also, involving the facial sensation also is the key. So if the patients complain also face, you should consider the disease is located in the brain or brainstem. Also, if the facial problem is unilateral, the same side of the body sensation problem, which would be the thalamic or the upper part, such as parietal lobe. But if the facial numbness or pain is contralateral of the body, the symptom location should be the mid-brainstem, medulla oblongata, or the lower part of the pons, according to the pathway of the sensation. So again, involving the face or not is very important, and you should ask every time. Also, again, please check other neurological findings such as moving, reflux, and cranial nerves. So, okay. So let's check one case. 44 years of female who come with sudden onset of right hand numbness Numbness area is the palm area and third to fifth fingers. Also, patients complain of transit symptom of difficulty speaking. So speaking problem also, it's a kind of cranial nerve disease. Maybe patients have some vagus nerve problem or not. I omit the physical exam information of this symptom. But because of the cranial nerve problem, you should consider that brain problem and better to check brain MRI. Here is the MRI. So diffusion weighted image shows a high intensity signal at the left parietal lobe, somatosensory cortex. So it's a ischemic stroke. Okay. Another case. This is what I asked you before. So the sudden onset of left side numbness, but also right face numbness also. So the contralateral of the body. Also, cranial nerve problem is positive. Patients have decreased the function of swallowing, no weakness of the body. This case, you should consider that the disease is located in the midbrain or lower part of the midbrain brainstem. Sorry. Here is the MRI. We can see the high intensity signal at the right lateral medulla oblongata. Here's a MRA or B-pass information which suggests right VA dissection. Sorry, there's no time, so I cannot explain detail, but the diagnosis is Wallenberg syndrome, which is an infarction of the lateral medulla oblongata. So the answer of the question is number 4. Okay. So I understand the neurology is not familiar to many doctors, but if you understand, I think it's very, very interesting area. So that's why I'm working until now. Okay. So second group is spine. So spine also have a variety of distribution, but it's not involving the facial area is the key. So central cord pattern is a bilateral, like number C of this image. And brown checkered is both sides, but the right side sensation problem and the unilateral, another side of weakness is we call brown checkered. Number E is a bilateral sensation. It's a transverse thoracic spinal cord, or the long area but the dorsal column, like syphilis patients. This 4 type of distribution, but all may have the spinal cord problem. So again, sparing the facial sensation is important, and then also you should check the neurology clearly and please take image like CT or MRI to find the cause, to find the disease. Also, time course is also important. Many spinal cord problems have chronic disease or subacute or acute, so very important to make clear the time course. Another case, 77 years old female who come with left leg numbness and pain. Also, patients have intermittent claudication. So this is a case in Japan. So the left leg numbness is mainly located in the L4 area and 3 years progression. Intermittent claudication is one of the common signs of the lumbar disc problem or ASO. But because of the numbness area, we should consider to focus on the nerve problem, lumbar disc herniation or canal stenosis. Okay. Right leg raising test is positive at the left side of the patients. So we took MRI. Lumbar canal stenosis is very severe with L3-4 and L4-5 disc herniation. So we performed the surgery of this patient to open the lumbar canal and remove several amount of disc to release the pressure of the nerve. So to assess the location of the disease, so again, you should understand the dermatome and please try to clarify the level of the disease. So the surgical indication may different. Which area you should release the nerve is depend on the neurological findings. So check the dermatology. DTR, deep tendon reflux, also important. Also, straight leg raising test is positive. Most of the case when the L5 or lower have problem. Femoral nerve stretching test is positive, usually when L4 or upper part has a problem. Okay, another case. 24 female have gradually progression of left side of numbness. The patient covers shoulder, body, and neck, but deny the facial area. This is the key. So we, from the upper part of body and lower part, but sparing the face, it could be the cervical spine area problem. Also, for these 2 weeks, patients have weakness of right side of the hand. So it kind of Brown-Séquard syndrome. Another side of weakness is revealed. Bicep reflux is positive. DTR right side decrease, but we are not clear this information about it. Again, so we check the MRI of cervical area. Central spinal cord disease, high intensity. The border is very vague. Was revealed at C3-4 level. We consider it could be the transverse myelitis or neuromyelitis optica. It's a kind of multiple sclerosis subtype. Some autoimmune disease may be suspected. Actually, we couldn't submit some specific tests because of it's expensive in Cambodian situation. So actually, I saw these patients in Cambodia. So we empirically started the steroid. Unfortunately, patients improved the symptom, decreased the size of the damaging area. Okay. So let's move to the number 3, mononeuropathy. Mono means it's a single. So the distribution is limited in one nerve root area, such as T5, C6, L4, like this image. So if you see these patients, please consider it about the peripheral nerve damage or compression of that place. So one typical disease is carpal tunnel syndrome, as you know. So the symptom of carpal tunnel syndrome may be self-limited, receding in about 6 months, or may require treatment. So it's a median nerve compression at the wrist area chronically. So the most common symptom is that this happens in the night or early morning, and often involve both hands, but it's a different times. So some morning the patients complain right side carpal tunnel syndrome, another day it's left side. So, and also important thing is that when patients shake hands, then the pain relieves. So we call it flick sign is positive. If the history of this, which means awakening with symptoms and shaking the hand to provide relief. If this history is positive, we call flick sign positive. It's a very high sensitivity, 93%, and specificity of 96%. So please ask this question. Another typical sign or symptom is that the distribution of the pain area or Farley maneuver, which means a compression, flex of the wrist and compress 1 minute, and the patient's complain of the pain or numbness of the median nerve area. It's a Farley maneuver positive. For Tinner sign, you should click or push the median nerve area and occur the symptom. This is a positive. So you should check these easy tests. Free, you don't have to charge the patients. Easy to ask and easy to check this exam. Then you should reach the diagnosis. About the treatment, again, so many cases self-limited, so improve gradually if the patient don't move too much. So sometimes we use splinting or injection corticosteroid or physical therapy is maybe important, including yoga. But if basically 6 weeks or more, if the symptom persists or worsening, maybe it's time to consider the surgery. So open the compression area and release the pressure may improve permanently of the symptoms. Okay. So sorry, I understand it's very quick and difficult case, but finally, the final category is polyneuropathy and also peripheral neuropathy we should include in this category. Basically, poly means a multiple location, but also sometimes or typical polyneuropathy is a symmetrical distal part, but sometimes it's not like that. So we should include other than the brain or brainstem or as a mononeuropathy problem, you should include this category. And then there are many causes which causes polyneuropathy. So very difficult to reach the diagnosis. From the articles like this, for example, AIDS, carcinoma, sometimes we call paraneoplastic syndrome, liver disease, kidney disease, diabetes, hypothyroidism. These are some typical findings. Another one is monoclonal gammopathy, amyloidosis, multiple myeloma, or another one, or syphilis, vitamin B6 or B12 deficiency is also common. Also medication side effects, there are many common medicine which causes neuropathy. Amiodarone is common, digoxin is common, and so on. So very huge. So you should ask very carefully about the history and some laboratory tests. So this article recommends some routine tests as complete blood count, comprehensive metabolic panel, including liver function, kidney function, ESR or CRP, fasting blood glucose, thyroid level, vitamin B12 level is recommended as a routine. A1C in Japan, we can take easily. Maybe in Cambodia also can take easily. So please check, because diabetes is very, very common in Asian countries, not only Cambodia, but other country doctors. If you listen, please consider as a routine one. Another test like HIV or urine or protein or anything else like ANCA, P ANCA, C ANCA, maybe depending on the patient's history. So I share two diseases which cause polyneuropathy. Let's check one case. This case is a 57-year-old woman reports increasing sensation in both legs for past 18 months. Patients have the history of chronic gastritis. Physical exam also patients have impaired position sense, Lomberg sign positive, impaired vibration sense, both legs. So the doctor doubt vitamin B12 deficiency and send the vitamin B12, but the level is within normal range. Blood sugar also within normal range. So what do you think the next step? Okay, so sorry, no time to ask to each, so I move. So the answer of this disease is a vitamin B12 deficiency. So the message from this case is that even if the serum vitamin B12 level is within normal range, you should still doubt the vitamin B12 deficiency. If you can send the methylmalonic acid level, and if it's high, it means vitamin B12 deficiency, so it's good to check. But if it's difficult to check, like a Cambodian situation, please start to prescribe vitamin B12 and as an empiric therapy, and please follow up if it is effective or not. So as you know, vitamin B12 causes megaloblastic anemia or demyelinating disease such as peripheral neuropathy like this case. And GI tract symptom past history of gastrectomy or chronic gastritis is a very high risk of vitamin B12 deficiency, because these patients cannot uptake the vitamin B12, cobalamin, from some food. So please be careful and please remember this disease. Then another important disease is diabetic polyneuropathy. Actually, in clinical situation, this is very, very common. So the location is usually limited at socks area, foot area, and it doesn't exceed the ankle joint. So this character usually tingling sensation or pain at soles. And beginning stage, there are no symptoms around hands, but finally patients may complain of socks and glove type area numbness. So first starting from tingling, then go to the numbness is the character of this disease. So maybe this pattern is a demyelinization of the nerve. So please understand this character. And about the treatment of this disease, it's controlling glucose is very important. So even if the patients have symptoms, and then if you start strict management of glucose, you may stop the progression of the disease. So some articles, some RCT shows that strict control is good also for neuropathy patients. So also lifestyle change like BP control, smoke cessation, alcohol cessation. these 3 points is also the cause of polyneuropathy, smoking, alcohol. So please be serious to educate the lifestyle change. Body weight is also important for that. About the medication, aldose reductase inhibitors, ARI, or some name is epalrestat, is a kind of new medicine to improve the neuropathy or retinopathy for the DM patients. But the evidence is not so strong and expensive. So in Japan, not every patient we use this medicine so far. Symptomatic therapy, if the patients complain of pain, basically we recommend to start amitriptyline, pregabalin, or duloxetine to decrease the pain. Numbness itself very difficult to improve. And some doctor prescribe mecobalamin, but because patient doesn't have vitamin B12 deficiency of this patient, so most of the case, no effect of mecobalamin. Okay, so maybe it's almost time. So let's share the final case. This patient's history is long, 56 years of male. Patients came here because of brain abscess. So the abscess is located on the left frontal lobe. At that time, no neurological deficits, only the fever and headache, and we noticed the brain abscess on the MRI. So after we aspirate the abscess, start IV antibiotics, patients go home and we start metronidazole PO. Then 30 days after starting this medicine, peripheral nerve symptoms start. Tingling, both leg tingling with gait disturbance. Also, CNS symptoms like disorientation, dystonia, and varismus in all limbs happen 75 days after starting this medicine. Here is MRI at that time. So we can see the T2 high intensity in bilateral dentate nuclei, tectum, splenium, and cerebral white matter, multiple area. This is metronidazole encephalopathy or neuropathy. So we stop the drug. Also vitamin B1, B12 supplement starting. Then his symptom improve a lot. 1 week, 2 week, the patient's symptom improve. Actually, numbness still remain a little bit, but much improving. So we are lucky that we noticed this disease. It's very rare, but the doctor in charge and knew this disease, and we can reach a clear diagnosis of this disease. So 10 months later, almost disappear of the T2 high intensity area by that disease. So I want to share all doctors to be careful of the medication side effect numbness. Then you can save the patients like that. So the take-home message of this lecture. So please clarify the distribution pattern and divide into 4 groups: brain or spine or mononeuropathy or polyneuropathy. And the cause of numbness or tingling is very huge. So please summarize all information and then please try to reach the real diagnosis. One more slide. So I want to share the information that we Apsara want to start to accept some case presentation or case question and want to have some discussion of the management or how to approach the patients with specialists in Japan. So we already gather several very good specialists in Japan in each subspecialty. So maybe we will announce soon how to accept and how to hold this discussion, case discussion. So please keep following our information from Facebook or homepage. That's all from me. Thank you so much.
Thank you so much, Dr. Hayashi. That's very, thank you so much for great lecture. Actually, I really do not like to see patients with neurological symptoms because I'm not familiar with neurological diseases and I have some trouble to identify the cause of the symptoms. So, but your lecture was very informative and the very important points became clear today. So now we are accepting questions from the audience. So you can ask any questions through Q&A button. So, and in the meantime, if there are some questions from the panelists, I'd like to hear that. So what about Aya?
Hi, that was really great discussions and I mean like lectures. So I have a quick question. So as Dr. Hayashi mentioned that the numbness and tingling is so subjective. And is that severeness of tingling and numbness, is that associated with the severeness of the disease? If the patient has like a brain or spine disease that's really severe, in that case, is that always patients going to have a severe numbness or tingling? Or some elderly population, they may have decreased the sensation, so they might have slight like numbness and still associated with the brain or spine disease?
Yeah, very good question. Thank you so much. Yeah, the answer is yes. So because for example, when I see patient one day, 10 or 20 numbness patients I see in one day, but most of the patients doesn't have any severe disease. So some elderly patient just complain of some weak, some slight numbness or slight tingling. It's very, very common, but not all patients we send some very rare disease. We don't doubt the rare disease. So if the patient's complaints very severe or very strong or some limit the daily living, maybe we should consider this is very real symptom and we should survey or we should try to find the real cause.
Okay, thank you.
All right, thank you. So we have the question in the chat box. May I know the dose of injection steroids for carpal tunnel syndrome? So dose of the steroid for carpal tunnel syndrome. And also any complication of injection steroids for carpal tunnel syndrome?
So Dr. Telefon, thank you for asking, but sorry, I don't remember the dosage, but I put the articles, so I please check my reference article about that. About the complication, actually, personally, I have no experience of injection. Usually, we neurosurgeon directly recommend surgery if conservative treatment didn't effective.
Okay. Actually, I have a question. So, Dr. Hayashi, you have experienced that there are four groups of neurological symptoms, which is brain, spine, mononeuropathy, and polyneuropathy. And in the setting of outpatient clinic, which groups of patients do you see the most often?
Yeah, most often it's very slight symptom polyneuropathy, I can say. So patients come, they mention the chief complaint right side numbness. But when I ask, do you have any other place, such as left side, the patient say yes. How about right side leg? Patient say yes. So something like that. Maybe you may have the experience. So, and also touching sensation, most of the cases are normal. So the actually physical exam is not some case not reliable because like physical exam, if can you feel this sensation or not? Also, it's a subjective information, including so very difficult to clarify. But yeah, so actually maybe the experience is also important. You should make clear that this numbness is real numbness or just a patient's worry and try to exaggerate the symptoms. So sometimes this may happen.
Okay, thank you so much. So Aya, do you have any comments or like questions about like this lecture or the things we have mentioned?
Did you say that again? Sorry.
Any comments about like we have dealt with some side effects of medicine such as metronidazole, or we have discussed the drug side effects of like polyneuropathy.
Yeah, I've never had myself that have experience of the drug-induced numbness, but when patient is taking those medications, it's always what educate patient if patient has developed some symptoms of numbness, then let us know. That's just as a pharmacist to inform the patient. And also, I was just checking on the injection dose of the steroid for the carpal tunnel. Maybe some of the articles saying that 25 milligrams of hydrocortisone might be effective or a little bit higher. That was I was checking, but it's not so strict or not really like developed, highly developed enough for the steady dose.
Yeah, thank you. Very helpful from pharmacist.
Thank you. So in the Q&A bottom, we have another question. How many dosage of metronidazole we should pay attention of its adverse effects?
Thank you. So from the literature, the dose depending. So actually our dose is already very high. So because we have to continue very long, like 70 days. So I'm not sorry, I cannot answer clearly not right now, but if you think unnecessary, you should terminate, of course, quickly.
Okay, so it can be dependent.
So actually, we don't publish this yet, but New England Journal of Medicine also have this disease, metronidazole neuropathy. I think it's last year. So please study from this literature.
Okay, I'll check the details and later I'll send the details to the participants through the email. I do so. Okay. So it seems like we have answered all the questions and the time is almost up. So I'm gonna close this lecture today. So thank you so much for your participation. The next seminar is planned on May 22nd and the time schedule will be the same. And the lecture title is A Practical Approach to Hypotension by Dr. Kozuma. So I'll send the webinar link to all of you so you do not have to sign up for another Google form. Also, I'll send the PowerPoint slides we used today to your email address after this lecture, or maybe it can be tomorrow. And also we'll upload a video to YouTube so that you can review the lecture again. So I hope to see you soon, like see you in a month. and have a good weekend.
Thank you so much.
Thank you.
Bye.
See you. Thank you, doctor.
Mm.